Hello guys, I'm Deepak Shukla. Welcome to our channel Study Mania. Today, let's learn about complications of ASOM and CSOM. So before moving that, we should know the routes of spread. So it can happen via the natural communication, that is oval window and round window. It can happen via bone erosions as a result of the disease like cholesteatoma and iatrogenic. It can happen due to venous thrombophlebitis. A point to remember is that they don't spread by lymphatic route. It is very important. Now let's know about the classification of the complications. So we have extracranial complications and intracranial complications. Let's enumerate the classification of complications of ASOM and CSOM. So we have extracranial complications, intracranial complications. In extracranial we have mastoiditis, labyrinthitis, facial nerve palsy, petrositis, osteomyelitis, and septicemia. Whereas in intracranial complications we have meningitis, extradural abscess, subdural abscess, brain abscess, lateral sinus thrombophlebitis, and otitic hydrocephalus. First, let's see about extracranial complication. Okay. Now suppose we have disease in the middle ear. Okay. And in the middle ear, and from the middle ear it can go to mastoid. Suppose this is the mastoid. So first one is mastoiditis. Okay, so it can cause acute mastoiditis. From middle ear only it can go and cause this bone, and it may affect this bone, squamous bone. It may cause osteomyelitis. Okay, so from middle ear to mastoid causing mastoiditis, from middle ear to squamous cell causing osteomyelitis. Now from middle ear we have labyrinths and this semicellular canals. If it infects this, it can cause labyrinthitis. Now, from middle ear only, it can affect this apex of petrous bone, causing petrositis. Okay, and the nerve, facial nerve passing through this, it can affect these, causing facial nerve palsy. Okay, so need not to by heart, just draw this diagram or learn this. From middle ear it can come back to mastoid. Okay, mastoiditis, it can affect the bone, osteomyelitis, it can affect the inner ear, labyrinthitis, then it can affect the apex of petrous bone, petrositis, and meanwhile affecting facial nerve, so it can cause facial nerve palsy. Okay, so nothing much to take ahead. The most common intracranial complication is meningitis in acute otitis media, and in chronic otitis media it is intracerebral abscess. The most common extracranial complication is mastoiditis, and for chronic otitis media it is post-auricular abscess. So this was about the extracranial complications. Now talking about the intracranial complications, again let's see the roots. Disease can break the roof of the middle ear, and that is tegment tympani, and can go to the middle cranial fossa affecting the brain. Then via the petrous effect affecting the cerebellum. So these are the roots. Okay, so if tegment tympani is being broken or eroded, it may cause meningitis, extradural abscess, subdural abscess, brain abscess, sigmoid sinus thrombosis, and then otitic hydrocephalus. So let's see the intracranial complication. Okay, now suppose we have brain here. Okay, so if it's in the brain, it may cause brain abscess. Okay, so this is, suppose this is the tegment. Okay, if it is being eroded, it can reach here. These are the meninges. So if the meninges are affected, it may cause meningitis. After that we have dura mater. Okay, so subdural abscess. Outside the dura we have extradural abscess, and if the brain is affected we have brain abscess. Here we have sigmoid sinus, so if it is affected it can lead to sigmoid sinus thrombosis. And then at the last, otitic hydrocephalus. The clinical feature of otic hydrocephalus is raised ICT, so we'll have headache, vomiting, and papilledema. This is to the dilatation of ventricles of the brain. Okay, dilatation of ventricles of the brain. Okay, so the treatment is you have to decrease the ICT, or you have to put some ventriculoperitoneal shunt to redirect the CSF. So this was about the complications, okay, intracranial and the extracranial that I have told earlier. Now let's see each complications in detail. Okay, the first one will have acute mastoiditis. Okay, This is the most common extracranial complication of ASOM. Most common extracranial complication of ASOM. What is the organism? Is Streptococcus. Pneumonia is the most common organism. Okay. Then we have beta hemolytic streptococcus, Staph aureus, Haemophilus influenza, Pseudomonas. So what are the features of acute mastocytitis? So here the features of ASOM are there, okay, along with some exaggerated things like it will be having pain, okay, fever, hearing loss, pain behind the ear. It is very important, pain behind the ear. And if we'll see, we'll have pulsatile as seen in ASOM, lighthouse sign as seen in ASOM. Okay, so pain, fever, hearing loss, and pain behind the ear are the features of acute mastocytitis. What are the pathophysiology behind that? Now, ASOM started with the ET tube obstruction, you all know. Okay, then it ascended to the middle ear. It affected the middle ear. Then the pus was created in the or filled in the middle ear. Okay, now the infection in the middle ear has to go to the mastoid through adytus. Okay, so this part, okay, connecting the middle ear to the posterior is adytus. Now this goes to the adytus and inflame these cells, okay, antral cells. Okay, inflammation of mastoid cells and pus in the mastoid. Okay, it's very easy. Eustachian tube obstruction, middle ear, from middle ear through adytus to the ear cells in the mastoid. Okay, as disease progresses, there is loss of septation between these ear cells. Okay, so here the septations are there. Okay, as disease progresses, there is loss of septation and everything will come into one, and that results into the coalescent mastoiditis. Coalescent mastoiditis. Okay, loss of septation, everything come together. So what are the signs of mastoiditis? Here we have ironed out appearance of the mastoid. It is the first sign of acute mastoiditis which occurred due to inflammation of mastoid periosteum. Then we have positive reservoir sign. Okay, now mastoid acts as a reservoir. So discharge rapidly fills up. Okay, because there is now pus in the mastoid also. So discharge rapidly fills up after mopping the canal, which is specific for mastoiditis. Then we have pulsatile that you see in ASOM, lighthouse sign, tenderness in the mastoid region on the Mac-Ewan triangle, sagging of posterior-superior meatal wall, perforation of pars tensa, okay, swelling over the mastoid pushes the pinna forward. Okay, so swelling over the mastoid pushes the pinna forward and downwards with deepening of retroauricular sulcus. So these were the signs of mastoiditis. Coming to investigations, we can do the X-ray and CT scan. Air cells become hazy here. Okay, normally the air cells are black in color. Here the affected air cells will become grayish. Now, what is the treatment? After doing the investigation, we go for cortical mastoidectomy. This is also known as Schwartz operation. Okay, also known as intact canal wall mastoidectomy. Okay, remove all the air cells, make it one single cavity. Okay, so this was about the cortical mastoidectomy and about the mastoiditis, acute mastoiditis. Now let's learn about some abscess in relation to mastoid. Okay, now the mastoid was here. So if it breaks the auricle, okay, so it can be post auricular abscess. The first one is post auricular abscess. Second one is if it breaks the sternocleidomastoid or spreads to the sternocleidomastoid, it is called Bezold's abscess. Bezold's abscess for sternocleidomastoid. If it goes to the digastric muscle, okay, digastric muscle, it is called Sitley's abscess. Okay, so first we have post auricular abscess, Bezold's abscess, Sitley's abscess, breaking the digastric muscle. Then if it breaks the meatus, okay, it is called Lux abscess, and it then goes to the zygomatic abscess. Okay, so these are the 5 abscesses in relation to the mastoid. Coming to the second intracranial complication, that is petrositis. Simply it is inflammation of petrous apex. We just need to know about the 3 marker here, that is Gradingo's triad. Okay, Gradingo's triad. Here we have 5th cranial lobe, 6th cranial involved. Due to 5th cranial lobe palsy, there is deep-seated retroorbital pain. Okay, deep-seated retroorbital pain, that is in the Meckel cave. And due to 6th cranial lobe involvement, as 6th cranial lobe supplies the lateral rectus, there will be lateral rectus palsy. Okay, Darolo canal is involved. And along with fifth cranial nerve palsy and sixth cranial nerve palsy, we have persistent ear discharge. So this was about the Gradingo's triad. It is a 3 mark. Okay. Coming to the next one, that is labyrinthitis. Inflammation of labyrinth is labyrinthitis. Coming to the types, very important. We have circumscribed labyrinthitis, diffuse serous labyrinthitis, and then it may go to diffuse suppurative labyrinthitis. Coming to circumscribed, there is localized area of erosion, and which is the most common canal to be eroded is lateral semicircular canal. Okay, you have to remember this. Lateral semicircular canal is the most common canal to be eroded. Here you have fistula sign positive. Since any pressure changes in the external ear are transmitted to the middle ear and then to the inner ear, this causes nystagmus and then vertigo. This is a reversible stage. Okay, circumscribed stage and then diffuse stage, these are reversible if treated well. Okay. Coming to the diffuse serous labyrinthitis, it is also a reversible stage. Entire labyrinth is filled with sterile fluid. Okay, here in circumscribed only localized area was eroded, but here entire labyrinth is filled with sterile fluid, which occurs due to inflammatory response from bacterial toxins. Labyrinth is hyperactive and irritative. Again, there will be nystagmus towards the affected site. Symptoms: there is single long episode of vertigo and sensory neural hearing loss. Okay. Coming to diffuse suppurative labyrinthitis, again, this is not that much reversible. So this diffuse suppurative labyrinthitis, here active infection is there, resulting in pus that destroys the receptors entire of labyrinths, and here it will become dead or hypoactive. Okay, but in the earlier stage it was hyperreactive and irritated. It is a irreversible condition. Clinical features: single long episode of vertigo and high grade fever because infection is there. Nystagmus towards the opposite side. Vertigo and nystagmus disappears in 3 to 4 weeks due to central compensation. Management is antibiotics with labyrinthine sedatives. Mastoid aspiration is needed to clear the pus. Okay, so this was about the labyrinthitis. So that completes our extracranial complication of petrositis, mastoiditis, labyrinthitis. Coming to septicemia, osteomyelitis, these are not that much asked in ENT, or you know all those things earlier only. Coming to the intracranial complications, I have told you, if meninges are involved, meningitis, brain is involved, brain abscess, outside dura, extradural abscess, inside dura, subdural abscess. Okay, then if it affects the sigmoid sinus thrombosis, otitic hydrocephalus, these things are the intracranial complications. So let's see each one of them separately. Coming to meningitis, again, it is the most common in ASOM, and there will be features of meningitis, that is Brzezinski's positive, Kernick's positive. Those all you know meningitis earlier only. So what to do? We have to go for lumbar puncture, CSF analysis, and then reduce the ICT. Okay, so meningitis. Coming to the extradural abscess, it is between the bone and dura and does not present with any symptom. Therefore, it is known as silent abscess. Extradural is silent abscess. Here you have to do again modified radical mastectomy. Okay. Coming to subdural abscess, it is rarest abscess, and again you have to do the same thing, modified radical mastectomy. Coming to the brain abscess, that is very important here. It is the most common intracranial complication. So what are the bones involved? What are the lobes involved? Temporal lobe of the brain is more commonly involved than the cerebellum. So in brain abscess, what are the clinical features? Here we have raised ICT. If ICT is raised, you will have headache, then vomiting, drowsiness, papilledema and bradycardia on examination you will find. Localizing features depending upon the lobe of the brain involved, like if temporal brain is involved, then hearing, then occipital lobe is involved, then visual problems will be there. In temporal lobe abscess, we have normal aphasia, homonymous hemianopia, contralateral motor paralysis, and epilepsy. In cerebellar abscess can happen. Ataxia, dysmetria, and dysdiakinesia can be found in cerebellar abscess. Okay, what are the features of cerebellar abscess? Diagnosis is made on MRI. Diagnosis is made on MRI where a ring sign is typically seen. Okay, ring sign is typically seen. Treatment is again medical, surgical. Medical, you have to give the IV antibiotics. Then you can go for the steroid, that is dexamethasone, and mannitol to reduce the ICT. Again, there is many criteria to use mannitol. There are certain contraindication and indications to use mannitol. Then you have to go for surgeries. Then neurosurgical to drain the brain abscess, and odontological you have to go for modified radical mastectomy for CSM and cholesteatoma. So this was about the brain abscess. Coming to the lateral sinus or sigmoid sinus thrombophlebitis. Okay, so this is also the intracranial complication of ASOM and CSOM. So earlier there was a normal bone. Okay, after that the bone is eroded. Okay, the part of the bone, this was the bone, so it was eroded, it was called periphlebitis. After that this erosion comes inside, that is called endophlebitis. Okay, then causing the lateral sinus abscess. So it was normal bone, then causing periphlebitis, endophlebitis, and then lateral sinus abscesses. So what are the clinical features in this? It is very important. Here you will see the hectic picket fence type of fever. Okay, this name is very important. Hectic picket fence type of fever with rigor. So this fever does not touches the baseline and represent like fence. Okay, so it does not touches the baseline and it represent like the fence. Hence, hectic picket fence type of fever is seen in sigmoid sinus thrombophlebitis. Then we have Griesinger sign. Okay, Griesinger sign, edema and bluish discoloration over the posterior part of mastoid due to thrombosis of mastoid emissary veins. Okay, don't confuse it with the iron out appearance of the mastoid. Then we have papilledema due to ICT, increased ICT. Then you have Tobbe-Ayers test. Here, compression of the intrajugular vein on the healthy side produces rise in CSF pressure. Okay, this is a test. If you compress the intrajugular vein of one side, that is healthy side, that will increase the CSF because other side is affected. Then tenderness over the jugular vein. The sixth sign is Kraubach test. So if you again apply pressure on the IJV, like intrajugular vein, on the healthy side produces engorgement of the retinal veins. Okay. Now the healthy side only if you are pressing, the affected side it will not like pressure will be more on that, then it will produce engorgement of the retinal veins. In contrast, you will find the delta sign and the empty delta sign. Okay. So this was about the signs of lateral sinus thrombophlebitis. Okay. And management depends upon the complications and investigations and other findings also. So this was just about the signs of the lateral sinus thrombophlebitis. Okay, hectic picket fence, Griesinger signs, papilledema, Tobbe-Ayers test, Kraubach test, tenderness over the jugular vein. Okay, thank you so much. This was about the complications of ASOM and CSOM. If you want to learn about the ASOM separately and CSOM separately, there are videos on that you can see. Thank you so much.